morning. Welcome, everybody. My name is Michelle Hood. I'm the Executive Vice President and Chief Operating Officer for the American Hospital Association. And I was really delighted to be asked to introduce this session, Retail Medicine Takes Hold. The AHA works across the healthcare ecosystem to accelerate improvement and innovation. We recognize that as healthcare expands outside the four walls of our hospitals and clinics and into shopping centers and homes, our patients expect a new level of experience and personalization. That's why we've added consumerism to our strategic plan. Today, we are in for a treat. Increasingly, patients are accessing healthcare in non-traditional environments. Retail stores from Walmart to Walgreens allow people to meet with healthcare providers while shopping for groceries and housewares and going about their usual daily tasks. The explosion in health apps, telehealth, and other technologies, including those offered by Google and Best Buy, empower patients to take charge of their own health without leaving their homes. So the question is, how are these advances changing the role of traditional healthcare providers? That's what we'll explore in this session this morning. Bertha Coombs is our moderator, and she's with us today. In her day job, she reports on financial markets and healthcare services for CNBC. She has chronicled the rise of telehealth, the expansion of government-funded health coverage, and how the increasingly vertical integration of health plans, providers, and retailers is changing the landscape of consumer health care. I'll turn it over to our panel.
Thank you very much. Good morning to all of you. Joining me to my left is Deborah DeSanzo. She is the head of Best Buy Health. Prior to that, she had headed up IBM Watson Health. And prior to that, she'd been at Philips Health. And some of you may have been here in 2017, where her wish and great idea was for a robot, Coco, that would help folks with dementia. Seems like you're sort of doing that now. Karen DeSalvo is the Chief Health Officer at Google. She says that she wakes up every day and making billions of people healthier is what she thinks about. She was in the Department of Health and Human Services during the Obama administration, was the National Coordinator for Health IT, and has since served on MedPAC, the MedPAC Advisory Committee as well, while still doing Google. I don't know how you do all of that. And still sleep, because we know sleep is very important for health.
So is running, so I got to squeeze all that into.
There you go, it's a lot to squeeze in. Deb, I want to start with you. You know, I remember as a kid going to an electronics store, and at the time, my parents were in the market for a washer and dryer, and I was more interested in toys and couldn't understand why anybody wanted a washer and dryer. Now when you go to Best Buy, you could get a washer and dryer, which obviously is very important for your health to keep things clean. But now you offer a number of electronics, a number of services for health at home. And I think not everybody really thinks of Best Buy as a health flywheel.
Yeah, Bertha, thank you. Thanks for having me. Great to be here, everybody. So I think if you think about Best Buy, you think about a consumer electronics retailer. And about 5 years ago, when the strategic team was thinking about where consumer electronics were going, you had to think about health. Even before the pandemic, you had to think about health. So they put together a strategy, and it was like, so where...
Why? Why did you have to think about health? Is it just because it's the biggest part of the economy?
Because consumer electronics were really... So consumer electronics started to come into health in a big way. So if in like 5 years ago, of course, there's the fitness equipment, right?
Right.
But then you started to get all of the wearables, the Fitbits, the Apple Watches, the Oura Rings. Then you started to get, talk of hearing aids going over the counter. Then you start talking about glucose monitors going over the counter. Then you have all of the remote patient monitoring devices, blood pressure cuffs, SpO2 devices, everything to temperature, the TytoCare device for family health. And so Best Buy really thought, in the same way, we have stores within the store, so we'll have a Samsung store within the store, we'll have a Microsoft store within the store. We could have a Google store within the store, but we said we need to have a health store within the store where people can come and learn about, from our blue shirts, from our beautiful blue shirts, learn about the differences or the health devices. So when the pandemic came, though, we moved a lot of this into our virtual store. So if, for example, you're interested in buying an exercise bike, we can't fit all the exercise bikes in the store. And looking on the web, you only get so much on bestbuy.com. So we have a virtual store where we have trainers. You can make an appointment with a trainer, and you can see how whatever it is, the exercise bike, the differences in the exercise bikes, and the trainer will get on the bike and work it for you. So it really came because the roots of Best Buy are as a consumer electronics retailer, and when consumer health technology was coming to foreplay, that's when Best Buy said we've got to make this a better shopping experience.
What's interesting, Karen, is that you've been involved with healthcare and technology for a long time, certainly on the software side. And as a doctor, I know they don't like to hear it, but we all consult Dr. Google before we go in to figure out the right questions to ask when we want to talk to our provider, whether it's through a telehealth visit or in person. How are you looking at health now, especially over the last couple of years, the way people have used Google to try to find information, and in some cases not finding the best information?
Yeah, the Dr. Google story was one of the reasons that I came to the company. As a physician, my patients were coming in and saying, I learned this or I looked this up. And a really important goal is to see that Dr. Google is trusted, high quality, good partner. And Dr. Google, though, the way most people come to us is through search or YouTube. And you're right, about 3/4 of people go on the internet to look for information before they hit the healthcare system. So for us as a company, we're a life company. We're part of what, when people drive places, they use maps. When people want to fix their dishwasher after they've already purchased it from you, and years have gone by, they look on YouTube. And we have in our founding DNA that it's about knowledge, success, happiness, and health. So as you say, Bertha, people are coming to us, so we want to meet them where they are on those surfaces, very consumer-oriented approach to that. Now, we do have other parts of the health journey, personalized insights, supports for clinicians, and ways that we think about the ecosystem, including some hardware. But the consumer-facing piece, particularly in the last 2 years, for us has really become an important appreciation for how partnership that we can have with public health entities like the CDC or globally like the World Health Organization or other organizations, maybe social care ones that are trying to reach out to folks. We can take that message they have and amplify it in a way that, I'll be honest, I joined the company about 2.5 years ago, right before the pandemic, and I practice medicine, but I also practice public health, and you're always trying to get your message out to the world. And in those early days of the pandemic, when people needed to know how long to wash your hands, y'all remember that? Mm-hmm. All these things that we were trying to help the world understand, these were ways that we could amplify the important messages of public health. And I think it taught us as a company that high quality information already exists. And what we want to do is make sure that it gets out into the world so that people can know how to protect themselves, how to protect their community. And now we're doing more to help them take action. Like in COVID, it was find a test and schedule time to get that done, to get a vaccine for myself. So there are ways that we began to learn in the last 2 years that people want to not only get information that's high quality, but also begin to take action. And we're learning to help them navigate in other ways into a curated ecosystem. We want to make sure that they find the best quality sites and services for them as well. The flooding of that high quality information is the counterweight we often do to the misinformation. And if we have time, I'd be happy to talk more about that. But our strategy is very much about raising high quality information and partnering, as I said, with authoritative organizations to get that message out into the ecosystem. and knowing that that information is an important determinant of health, so is action, and giving them tools and agency to be able to then take the next steps to get the care they need at the place that takes their insurance, get that appointment, and then take on other personalized insights as is necessary for their health.
It's an interesting thing. I think, I had done a story a while back at Ochsner, and they were one of the first hospitals that actually had basically an e-bar where they would prescribe devices, and they would sell them at the hospital. But I imagine now you work with the payers, insurers, work with how many of them now? A few hundred? And you work with health systems as well. How do you coordinate with them to be able to help people get something? Because I have to imagine there's some people who sort of think, obviously there's the worried well, we want to quantify our steps, and my husband wants to beat Strava on his Garmin, and make sure that everything is, if we go for a walk and it's not quantified, he's not happy. But then you have the other folks who might be lost, and particularly for caregivers. When you're navigating two generations, one generation that might not be tech savvy and might not welcome the technology, the other generation that is trying to help that parent or grandparent to maintain their autonomy.
So there's a lot there, and you are right. People's needs over the arc of their life change. So we, in our consumer health going into Best Buy, people generally who are healthy and want to stay healthy, and what device can help me stay healthy. On the other end of the spectrum, when we work with our payer partners, the payers will run an assessment of who needs the most help, and the names will come to us. We have social workers who call and find out really what the caregiver and what the caregiver, usually a daughter or a son or a family member, and what their parents need. And then we will endeavor to provide it. So usually there is always some sort of device that is going to be there so that you can call for help, or that will be there in case of a fall. But there are other things that are needed as well. Maybe a remote patient monitoring device is needed to monitor something, but maybe it is also that people need a ride to get to their doctor's appointments, or maybe they are food insecure, so we work with food banks to help them get food, or maybe. So
you do that as an extension of the health center?
So there's a service, a monthly prescription service, and the payers, Medicaid, Medicare Advantage is the payer, and it is our job to find out what is needed so that Mrs. Smith will get to her doctor's appointment, will prevent a fall, can call for emergency services if they need it. What is needed for the holistic health of Mrs. Smith. So that's on the whole other end of the spectrum. In the middle, you have people who start to age, who are then thinking, well, I need some sort of device or service that's going to allow me to call for help, watch if I'm going to fall, enable me to connect to a caregiver, get me a Lyft ride if I need one. And those are sort of the people in the middle.
Bertha, if I could, I think in the beginning, when digital tools were coming out, they were thought of as kind of gadgety and fun, and the O-Bar at Ochsner I thought was really amazing from New Orleans. So, but I think, but even that it wasn't thought of as integral. And the way healthcare was when I was practicing and training was that we had essentially a brick and mortar physician-centric enterprise that people came to us, and we might have done a little bit of customization of the appointment type or length, but by and large, it was a pretty standardized experience. The way people want to experience care now is they want to be met where they are, wherever they are across the arc of their life journey, across the arc of their needs, physically where they are. That's one piece of it. And technology allows us to do that, to meet them where they are physically, emotionally, socially, which is the second big piece I think that digital is enabling and supporting that Deborah's describing, and that is that health is more than healthcare. So if we want to generate health for people and communities, we have to understand also their social needs and the context in which they live, learn, work, and play, these social determinants of health. And so when you're outside of the doc's office or outside of the hospital in the real world, there are inputs to your health, and these digital technologies enable us as a when I say us, I mean those who care about driving health, to be able to, again, meet people where they are, but also address more than just the right dose of insulin for the diabetes, but what is the right diet that they should be on, and that how do we help them make sure they have access to that food and exercise and all the other things that matter. It's actually incredibly
exciting. Is it actually happening? Because I mean, we've talked about it, and it sounds like the right thing to be doing, but the reality on the ground in terms of, for example, social determinants of health and equity. So the payers allow someone to be able to get that $200 Tyto Care device so that you can have a remote visit, right? Because most people aren't going to be able to do that.
The Tyto Care is actually a beautiful example of what Karen was just saying. So you can, if you're a caregiver, you can say, okay, I really want my mother to have this Tyto Care device that measures her temperature and
or be able to, for the clinician to hear her heartbeat without having to go into the office.
Exactly. But then it's more than just walking into a Best Buy and buying a Tyto Care, right? Because somebody has to be able to use the Tyto Care, either the caregiver or the mother. And so we put a little service around it that here's how you, I mean, it sounds incredibly low tech, but here's how you put the batteries in the Tyto Care.
Yeah.
Here's how you recharge it. Here's how you turn it on. Here's how you can use it. And then, of course, we provide people on the phone that after all that is done, if somebody still can't use it, they can call somebody and say, I can't connect this thing to my doctor. Well, and they'll walk through how you connect it to their doctor. So it is really, I love that. Meeting people where they are and ensuring that they have the things that they need that are going to keep them healthy. And we always say in their home. Our mission is really to enable people to get care from their doctor. Best Buy doesn't provide care, but to get care in their home as long as they possibly can.
To your question about is it really happening on the ground, what also has evolved in the last few years is that there are, through the payers, allowed ways to provide those funds. So when things like the OBAR started, it might have been an add-on that people had to purchase. There might have been some private plans that were supporting it. You're finding that this is much more common in Medicare Advantage plans.
Right.
It's a really exciting, pioneering area of innovation because they have global budget, because they're responsible for the health and the cost of someone's life across time. They're really interested in all those other drivers of health. And I mean, with transparency, I was on the board of Humana, which is an MA plan, and one of the reasons I did that was because it was such an exciting way to think about providing services and supports for somebody that was not only access to great medical care, but in the home, addressing loneliness, addressing food access. And so they have the flexibility and the funding to do it, and they're driving a lot of innovation in services, whether that's hardware, software, or even services that are startups that send college kids into the home to work with seniors so they're not lonely, because that's equivalent to smoking. Medicaid has picked up some of this. There's some exciting state innovations. So in low-income populations, in states like North Carolina, they've had the opportunity to use some flexible funding, again, to address social determinants of health. These are, what's interesting about this, just to say, like, there's all the happy good stuff, is that there's also, which by the way, some health plans provide housing for people.
Right.
Because it's such an important determinant
And
of health.
health systems are also.
That's right. Yes,
investing in
but then you think about, well, then is my ability to get food or sleep in a safe place predicated on the type of insurance I have or the insurance company I have? So what I guess personally what I'd love to see is that we think as a society that it's not just anchored on a benefit package, but that we're actually making sure that grandma or anyone has a safe place to sleep. But until we get to that time, that we're really addressing context more broadly and support. What I'm trying to say is really support the human services and social services infrastructure in America. I think it's really an exciting and good thing that health plans have this additional funding that they can provide support.
And I couldn't agree more. And I do want, so we have the Blue Cross Blue Shield Association is here, and so we have 100,000 Blue Cross Blue Shield members that are on the service. And you just mentioned loneliness, and I don't know the statistic for the 100,000 that are on the Blue Cross, but we take 9 million phone calls a year in our calling centers from seniors. And of those 9 million, only 10% is urgent response. I need help. Most of the other 90%, you could track back to loneliness. Even if somebody is calling about their bill, they're calling so they talk to somebody. Yeah. It's really amazing. And if we can get at loneliness, then we get at a lot of the decompensation, the people getting sicker over the course of their lives. So yeah.
Yes, and I think that is an amazing statistic, by the way. And I'll just add some knowledge to this group in case they don't know, which is that there's research that shows that loneliness is equivalent to smoking with respect to needing to be hospitalized or show up in the emergency room. So it actually has a through line to medical outcomes and is worthy of addressing. But that is 100%. And in practice, we see that. Like the patients want to come in because they need a thing to do. Like they just, and so figuring out a way that you can address that need and not over-medicalize the loneliness, but actually address it socially.
You know, both of you are very involved with AI, artificial intelligence, machine learning, to help support all of these efforts. I know we're very early on, but I did want to get your thoughts on Web3, metaverse, whatever this next sort of immersive technology as we move forward. I know it's like very early innings. We might even just be, you know, maybe like on the bench still.
The companies are pointing at each other.
Yeah, I'm just
you go first. No, you go first.
How do you think this could help on a consumer level for healthcare? I can see how it could help surgeons. I could see how it could help for training.
Sure. Yeah, I mean, the opportunities for, look, first of all, we're in a data economy, and there's lots of information available, including in people's electronic health records, that they can permit their health systems to then begin to build tools. We work, for example, with Mayo to help them improve imaging and diagnostics work, so identifying the cancer better, sooner, applying the radiotherapy in the right field so you don't damage nearby organs. That's an example of ways that AI can be applied to improve clinical practice. And by the way, that kind of tool then isn't just available in Rochester, Minnesota, but Mayo can make it available even globally, which I'll speak on their behalf, is something that they've said publicly. So AI does stand to augment and really support and give everybody access to super high quality care. Also work for consumers. It's possible to imagine a world in which consumers have access to those tools too, to get a second read on their mammogram or to understand better their own care, to not have to rely on systems. And we're doing a lot of that work at Google in partnership with others. I think your question about metaverse has also to do with, as the data and AI have gotten more sophisticated, more and more there are opportunities around language models that have enabled things like Echo and Alexa and Google, and it creates an interaction that can be information finding, and what we are seeing and understanding at Google is that people want an omni-channel approach. We talk about omni-channel in healthcare all the time, right, but people want an omni-channel approach to getting information. We're principally an information company. So they want to ask, they want to take a picture, they want to type in the bar, and they want to do that they want to know that if they can do it on one of our surfaces like YouTube, that it's possible that they might also be able to find something similar on Maps or somewhere else. And we depending on geography, age, and other sort of global characteristics, people use those platforms differently. So pulling that all together, it means that we've got to make it easier for people to get the information that they want. And artificial intelligence, AR and VR kind of leads you into that next immersion world. And we showcased at our I/O event last March ways that we're thinking about that on Maps, for example. Don't giggle, but bringing back sort of a Google Glasses, they're going to giggle, to enable you as you're walking and make the map come to life. Take a left here and show you what the name of the street is.
So sort of like Minority Report, except
Yeah.
in a better way, hopefully.
In a good way. So we are definitely, like every tech company, trying to understand that immersion experience that people want, but making it lighter and making it mobile. But also making it a part of all the other ways that people want to access knowledge and information and take action. So I do think you're going to see a lot more of this. It's going to be expected, I think, for generations that are coming up. I always say, I turned 57 yesterday, so I'm going to be on Medicare. And,
you're a kid.
I'm going to get all the birthday juice I can. So I'm going to be on Medicare, and how many years is that? 8 years? Yeah. And when I'm on Medicare, I'm going to want technology to meet me where I am. I'm going to want to not have to, go down to the doctor's office for everything. And so I'm already, as we think about planning for even seniors, we are going to have different expectations about how technology is going to enable health, just like generations below me have a completely different expectation about how they want to blend virtual reality and real life.
I like to tell people now, AI is just math. It's just really math. It's just really math. But
isn't it really an experience, though?
It's just really math. But so we use AI in very practical ways. In the old days, 7 years ago, fall detection was just 3 accelerometers to measure if you fell and how fast you fell, and therefore are you really on the ground. But now our models for fall detection are very sophisticated, and it goes from fall detection to analysis of gait, to prediction of fall, to what likely could happen with this gait change over time. So we use AI models for that. We were talking out in the hallway. We actually use VR now in these calling centers that we have. 1,400 caring center agents. I like to call them beautiful, empathetic caring center agents, because the calls that we hear from our members thanking them just warm your heart. But they need to go through sensitivity training, because they are taking calls from people who are 65 years and up. They're taking calls from a lot of people in their 80s and their 90s, and they need to have a good sense of what their member is going through. So we use VR actually to put all of our caring center agents, our engineers as well, but our caring center agents through sensitivity training. And this story is about a woman named Millie, who is in the early stages of dementia, and what she's going through when her family members come in, when she can't remember where she put her keys, when she's sitting in a large group, when she suddenly finds herself in a place where she doesn't know where she is. And it's incredibly powerful to sit with the VR glasses in the eyes of Millie. So it's very effective there. I would say in healthcare, VR is in its early stages. Startups are starting to use it for physical therapy, and you can imagine how using VR for physical therapy could be very helpful. I think there's a lot where we could go. When I was at Philips, we did one of the first pilots with Google Glass. We thought it was phenomenal. So physicians could see information. So I mean, there's just a very bright future. We're in the beginning stages of VR, I will say. Yeah, beginning stages.
Well, I want to open it up to the audience, and there's a hand right now, but I will give you one caveat. If you could wait for someone with a microphone to come so that we can get it all on a recording and we don't just hear it here in the room, but later, or if someone is watching, they can hear it. So I think here in the front we have.
Good morning.
Good morning.
Very interesting. Over-the-counter hearing aids. I think we have a huge issue where we have the FDA still hasn't approved over-the-counter. If you try to get someone to help you with over-the-counter, there's all kinds of hearables and blah, blah, blah out there. No one will help you with it. The audiologists, no. But many people can't afford hearing aids, right? Medicare doesn't pay for hearing aids. So there's this huge gap that people need help. Can companies like yours fill the gap?
I do not want to do an advertisement for Best Buy. But on bestbuy.com, you can log on to the health plays and get a hearing assessment. Now, we were really hoping, and we can't do, but we were really hoping, and companies were hoping that over-the-counter hearing aids would be here by now. They're not yet. There are other companies, Eargo, that provide hearables, but you can get a hearing assessment on bestbuy.com, and there is in the virtual store blue shirts that help you with what's available over the counter today. That's probably all we can do as a retailer. But we hear you. We were very, and we still are, very optimistic about over-the-counter hearing aids. But you know, you of course need a qualified hearing assessment as well. So let me just say that.
In the back, the gentleman in the blue plaid.
Mike, hi. Appreciate everything you guys are doing to move healthcare closer to the consumer. My name is Dave Callion. I specifically work primarily with the veteran and military health communities. Karen, great to see you here. And because of our mission, we really are kind of the integrated payer providers taking care of folks in rural, highly rural, urban, and everything in between across the country, and have a responsibility both as payer and provider to take care of the entire health benefit. But I think it goes far beyond that. And we've started to allude to that a little bit around social care and how much that impacts the rest of your health care. Even dental care is considered not medical care, and 85% of veterans don't have access to dental care. So if you've worked in an emergency room, you know what that looks like, and that impacts things like chronic pain management. But if you think about housing, you think about education benefits, you think about access to transportation, social isolation, there are services available, but kind of funding streams that are not very clear today, and the movement towards social codes that allow you to then look at like a Unite Us platform and get all of those all those services organized around that beneficiary is really important. What do you see as the interoperability kind of movement as we started to get our heads wrapped around the electronic health record? I feel like there's a lot of steps between here and where we need to be, and I was wondering what you guys are doing towards that.
First of all, I had the opportunity to train and take care of veterans when I was baby junior faculty at Tulane, and so a big place in my heart. And you're 100% right about the opportunity that the VA has taken advantage of to think holistically about health, and that formed a lot of my early thinking about what was possible. And I think the reality also of what the VA has built is a trust model with the veterans, so that they know they can go for service and support, and they have a longitudinal relationship with the VA. And we know they seek care in other places as well, but there's this anchor trust. And I think that really matters, because then they're more likely to open up about some of their social needs or their mental health needs, in addition to their physical health needs. And they're trusting not just the provider, but the institution to help them. I want to say a word about Z codes, and then I want to talk about interoperability. Here's the thing about the Z codes. For those of you who aren't aware, it's a when we see you in the clinic or see someone in clinic, we document what we think are the diagnoses, and we can use that as a way of billing. And it goes into your record that you had diabetes, but maybe we also thought you were homeless or had a criminal history, which are a couple of the Z code options. And the thing about it is that what I worry about is that we document and stigmatize people by the way they look or by things that we might have gathered, without really understanding it doesn't always come from the patient. And those should be anchored on doing something about it, not just saying this person's hungry or doesn't have a safe place to sleep. The VA can take action, but not every institution feels that obligation. So I just hope folks are thinking about, let's not just label, let's act, and let's not label inappropriately, because it could have significant implications for people's lives. But there is a lot of activity happening, as I know you know, in the ecosystem to see if we can bring healthcare data together with social care data, sometimes asking people through platforms like Unite Us or other platforms about their needs, and then weaving that into a more holistic picture of their health and health needs, and then taking action. There's great examples of how this has worked well in programs that use this technology. Kaiser uses Unite Us. I'm sorry to call out a brand, but it is the biggest national brand. Unite Us is a technology interoperability platform. It's a way to get people linked to social services. So there are big national systems and payers using it. But I think this goes back to what I said earlier, is that we can identify the need, we can want to help get the need, but when you reach over to the food service provider or the housing provider or the transportation provider, they're largely funded on soft money and grants, and they're struggling to keep up with the demand. So again, we have to step back as a society and say, if that matters to health, how are we going to support the social care ecosystem and not just identify and sort of refer people, but make sure that they're able to receive. And the VA has, again, going back to them, thought about that, and so have some other organizations, but I'd say we're in really early stages of making sure that when we send that referral, that people can get the help they need consistently.
Does it, I mean, you're global, does it work any better anywhere else?
Oh, it's such an interesting question, because I think it does in some places. So, you know, famously, Singapore has a really strong social care system, very strong public health system, very strong healthcare system. But even there, their data doesn't interoperate in the way that they really want yet. They're stronger on the public health and social care side than even on the medical side. In the I was just in England last week. We do a lot of work with the NHS, and a big push for them coming out of the pandemic is to see that they're linking the medical care system with the social care system. Same issue. They have a social care infrastructure and a medical infrastructure, but you know, it's not that never the twain shall meet. It's just that they haven't really thought about those digital and other bridges. And so you're seeing even where there's a strength, there's still this new, I guess, I don't know if it's new, but it's certainly more headline coming out of the pandemic, that you can't just give the person the antiviral, antibiotic, the vaccine. They're also going to need to be, especially if they're in home isolation from COVID, they need food. So I think there's a push globally, but I'm not sure, with the exception of maybe Scandinavian countries, that anyone's really solved it well.
Very interesting. I think gentleman back here. This gentleman.
Morning. Dr. Zavo, thank you both for being here. Between GCP, Azure, AWS, you all probably have coverage across, you know, the vast majority of healthcare systems, healthcare payers, life sciences companies. I know you all are fiercely competitive. Any vision or discussions around coming together around interoperability, because you all have access to all the data that needs to be shared across the ecosystem? And there's, you know, you all have different incentives than, say, Epic, Cerner, and the EMR companies do, and so probably in a better position to actually take action in that space. Or in general, what do you see as your all's roles around healthcare interoperability?
Yeah, I used to think that interoperability was more of a business choice and cultural problem back when I was national coordinator, and not a technology issue as much. It's actually there are a lot of technology issues that still have to be worked out. And I can't speak for those other providers, except I will say for Oracle, who just purchased Cerner, that they had an event that was broadcast, and clearly Larry Ellison and I know David Feinberg, who runs Cerner, are very interested and committed to interoperability between the healthcare systems. It doesn't solve the outside of the healthcare ecosystem, but let's take that as an important first step. But for us at Google, interoperability and harmonized data standards is kind of what we're all about, right? We create platforms that developers can work on, and in fact, in GCP and Google Cloud, we have an API that makes our cloud interoperable and allows for a cloud agnostic environment. We are working on a FHIR standard. This is a kind of a better, smarter, faster, cheaper open standard that is used globally, and we're working on maturing that standard even further, because we've been able to map data in the EHR, we think, better. And but the point is that for us, we're also working with the ecosystem, we want to make that an open standard that everybody can use, not a proprietary standard. So it is our philosophy in the way we would like to go forward. I would hope, to your point, that it is of interest to others. But I would say to everyone that there's a governance piece of this that the US government has put in place, this TEFCA, because it's not just about sharing the data. It's about people whose data it is, understanding transparently what their choices are about sharing and giving consent, and that it's not just that the organizations decide to share. So I do want to focus on the fact that there's a foundation of technology, but there has to be governance that includes people and that their voice is heard about how that information is collected, shared, and used.
Is that the part that makes it more complex? Because I think about the fact that, you know, I've been you can travel around the world and get money from your very own bank account from an ATM. The other side of the globe, it's secure, and we can transfer funds around the world secure, and that's very highly regulated. So that's all interoperable on the financial level. What is it that's makes it so much harder on the healthcare level? Is it just the level of data that we're collecting?
Oh, it's a myriad of things, but important to recognize again consent in all of this. But some of the problem is when we began to digitize the healthcare experience of Americans. So George Bush called for everyone to have their own electronic health record. We have exceeded that goal. Now you all have multiple electronic health records that don't talk to each other. Right. Congratulations, America. And so that getting rid of hyperportalosis is to get everything into one system. But when all those systems grew up, and it was a rush of funding. So we all remember it came out of a stimulus act. So it was spend the money really quickly. So whoever was out there in the field, the Epics, the Cerners, Meditechs, they started to stand up all across the country, and they had proprietary standards. It was the Tower of Babel. None of the systems talk to each other. Somebody might say, if you have anyway, the way that they actually coded things. So if you were, I'm going to go binary, if you'll allow me, binary gender, just because if you think 15 years ago, most of it was that way. A woman is a 1, a man is a 2. Some other systems would make a man a 1, a woman a 2. Some would have 0, some would have 1. So mapping all that data to make sure even something simple as sexual orientation, gender identity is understood is a technical exercise. But then if you begin to move into blood pressure, is it a continuous variable, is it categorical? And we made a lot of progress. I'm going to be proud of this. When I was national coordinator to get to the US CDI, which is a skinny list, I used to say it's what I carried in my front coat pocket on my index card of this, Miss Smith is an 83-year-old who's midway with heart failure. These are a few things that you need. Let's not try to boil the ocean. But then, but it's so some of it is just getting the systems to talk. But the technology policy in America is it has a lot of continuity. So I want to give people hope. Because at least from a policy standpoint, no matter who's the president, you'll see that all of us built upon each other into this day to see that we're having more interoperable systems, and that's a good thing. But there are, I think you can get we could get further if people would let the data flow on behalf of consumers. That's a longer topic about blocking, and it does still exist where systems hold on to data. But the technology is not insurmountable. It's just work step by step by step.
I do want to go on that hope, though, because of the work that you did, 21st Century Cures Act, and because of the APIs now, from someone who has always had to get the data from patient monitoring or whatever I was doing into the EHRs, it is much easier today than it was 5 and 7 years ago. And it's pretty good. So our hospital at home platform, we have to put the information into Epic, because what good is it taking care of somebody in their home and not getting the information into the electronic health record? It is significantly more easy today for us to get information in and information out than it ever was before. So, and that's because of the work that was done, ONC, yeah.
That is a good note to end it on. But I just want to have each of you maybe a little closing statement. 5 years ago, you dreamt of AI being able to help someone with dementia, someone who's lonely. Where would you like to see us 5 years from now?
The same thing. I called her Coco, cognitive assistant, and after this we have robots coming out, but I still really do. An empathetic, caring cognitive assistant that knows my habits and knows when my habits start to decline and knows when I need more help and knows when I need to have a step up in my healthcare. That is still my dream of having, and not a hyped up thing, just a really caring, empathetic cognitive assistant who can use machine learning to track my daily activities and recommend to my caregiver what's going to make me healthier.
Nice. Well, I would like to see that this kind of consumer-centric universe of health exist, and to get there, I think what it means is we have to not only inform and educate people, but help them find their agency, like know that they're in control of their journey and their path, that they have that sense of power when they arrive in the healthcare environment or anywhere else. And I think in this world, one of the important ingredients is there's power in their own health data. And so while it's important for your doc to have access to your health record, you should too. It should tell the story of your health from birth to death, and you should know how that's going to be used to help you, because the opportunities are pretty extraordinary if you think about how, given that environment and the kind of hardware ecosystem that Deborah's talking about, it can enable and support you and nudge you in a minute-to-minute basis, but it really, but it can also help you find the right influencer on YouTube that's going to speak to your heart and help you on your health journey. So I just would really like to see a power shift, I'll say it that way, to the consumer being a lot more in the driver's seat.
That is a great vision, I think. Thank you both for a wonderful conversation, and thank you all for great questions as well.
Thank you.